Hello everyone, this is a 72-year-old male with a recurrent left medial inguinal hernia who presented with data of an strangulated hernia. We performed this with a robotic approach, with a tap procedure. As you can see, there is the bowel, and it's really incarcerated in that small recurrent medial hernia. So I don't want to do a lot of traction in the bowel because I have the fear of maybe perforating it if it is not perforated. So I decide to increase the length of the orifice where the bowel is incarcerated. As you can see there are some sutures of the previous open abdominal repair. These patients had an open radical prostatectomy, then developed a bilateral inguinal hernia that were repaired with an open approach by other surgeon. Here you can see the small bowel that was strangulated and was suffering, but it appears to me that the bowel was not necrotic, just ischemic, so I decided to continue with the procedure. After watching a lot of videos here in this page, I have modified my flap, so I start in the medial umbilical ligament and I take my dissection of the perineum all the way lateral to the almost to the iliac crest. With this size of the peritoneal flap, this allows me to do a large dissection and being able to always put a large mesh, usually an extra large 3D Max mesh. I like to do the dissection in the most symmetric way possible in order to avoid to work in small tunnels. I usually prefer to start the dissection in the median size of the radius or zone 2. And here you can see some scar of the previous open prostatectomy. In this point is always easier to identify the rectus muscle and leave all the fat inferior attached to the bladder. And as I mentioned before, I like to do the most symmetric possible way my dissection, especially in these cases where I am expected to find scar tissue, especially in the zone 2 of the section. Here we can see the sac that is incarcerated and the small portion that I opened. When I am dealing with direct hernias or medial hernias, I like to dissect between the cord structures and the sac and do my dissection from lateral to medial. So I am protecting the large vessel, and in my mind at least, I diminish the risk to cause an injury in these large vessels. Here we can see the fascia transversalis and the addition of the sac. I am taking down these additions and trying to identify the Cooper ligament. I always do these surgeries when the patient has a recurrent inguinal hernia or has a prior prostatectomy. I always put a Foley catheter and leave it there during the surgery. So this maintains the bladder collapse and diminish the risk of causing injury on it. I'm doing the dissection as the critical view of the myoepithelial orifice recommends, identifying the pubis and taking at least 2 centimeters to the other side my dissection, and also creating a space between the pubis and the cyst and the bladder. Sorry. Here you can see there is a lot of scar and some addition of the bladder to the pubis. So if it was an emergency surgery, it was in the midnight, so I always prefer, if I think that might be risk of causing injury of it, then take my dissection away to an easy part so I can think better. So now I'm going to the zone 1 dissection, carrying out the peritoneal flap as posterior as my medial dissection has been done, taking in mind that in the lateral part of the dissection, the fat, it's better to push it against the muscle so it will recover the nerves and will diminish the risk of postoperative pain. In this particular case, since the patient had a prior open radical prostatectomy, we will not see the deferent. Just we are going to see the spermatic vessels, as you can see here in this part of the dissection. I always try to carry as posterior as possible this peritoneal dissection, especially in this reflection of the peritoneum against the large vessels, especially to avoid the flexure of the mesh when we close the peritoneal flap. Here I can see a large tubular structure. I am not so sure what that is, but I'm going to leave it there. It goes down to the bladder. That movement of the left hand is something that we can only achieve with the robot. So that is what I see. I cannot dissect that scar and identify the Cooper ligament, so I'm touching it and taking down the scar as slowly and mindfully as possible, especially to avoid a bladder injury. I'm always asking my bedside assistant to look out for the Foley catheter and the bag, that it will not get insufflated. And if it is insufflated, then it means that we have an injury of the bladder and have to identify it and close it. Fortunately, this patient, we did not have any bladder injury. There we can see the medial defect where the hernia was and that we enlarged. We're doing some hemostasis, and it seems to me that the dissection is almost achieved. Now I'm going to reduce this cord lipoma to identify the inner ring that Dr. Lowry has perfectly described in his videos. Remembering that the core lipoma that we are taking down, it needs to be always anterior to this inner ring. If this is posterior, we are getting into another plane that is not the correct one. Here we can see the inner ring, the spermatic vessels, and now I'm going to do this maneuver that I traction the flap to see if there is any more dissection that needs to be done. To me, I need to take down this scar that is in the mid-pubis in order to accomplish the adequate mesh position that needs to be between the pubis and the bladder. Now I am happy with my dissection. I usually use a 3D Max mesh. I'm going to close the defect because I want to diminish the risk of postoperative seroma, and especially to increase the surface that is in contact with the mesh to create a better scar and a better integration of the mesh in this plane, so diminishing the risk of another recurrent hernia. Now that I have closed it, the stitches are really just grabbing the transversalis fascia. Those are not a complete stitches. I fixate the mesh with suture, usually a couple of stitches in the Cooper and the pubis, and one stitch in the rectus, and another in the lateral anterior aspect of the mesh. As you can see here, I'm going to check out the small bowel again, just to be sure that it regained its adequate irrigation and there is no risk of leak or perforation after the surgery. I am happy with the result. So I'm going to close it, the peritoneal flap, and desufflate the retius space to see that the mesh is well adosate to the surgery. This patient had 6 months of postoperative evolution with good results. He went home 8 hours after the surgery, 12 hours after the surgery. Thank you for watching.